Good afternoon. Um, First, I would like to thank the organizing committee, in particular Professor Perovic and, Professor Kojovic, for this kind invitation to participate in the 7th Adriatic Urology Forum. It's my first time in this beautiful city of Budva, but surely it won't be the last. I think I will come back at least for some holidays. It's a beautiful place. My talk will be on posterior urethral obstruction associated with and lower urinary tract reconstruction. This chapter deals with the biggest disasters in reconstructive urology. Most of these complications result from prostate cancer treatments, or, well, I should say, complications of pelvic cancer treatments, mainly prostate cancer, but also rectal cancer and bladder cancer. I'm going to talk only on complications on male patients. I have no disclosures, sadly. When we deal with this, topic of posterior urethral obstruction or stenosis, we have to dichotomize this topic into two portions. Cases where the prostate is still in situ, and cases or scenarios when the prostate has been removed. So if we're dealing with patients after prostate removal, we will deal mostly with vesicular urethral anastomosis, anastomotic strictures. On the other hand, if we're dealing with patients that still have a prostate in situ, we'll deal with bladder neck stenosis or contracture, prostatic urethral stenosis. These are stenosis that involve the whole prostatic urethra, and bulbar membranous urethral strictures. So in short, there are three scenarios that we need to deal with and reconstruct. So reconstruction of the vesicular urethral anastomotic strictures following radical prostatectomy, bulbar membranous urethroplasty, mainly associated with the radiation strictures. We cannot explain why, but most of these external beam radiation strictures affect the bulbar membranous urethra. We assume it's because it's the least or the most compromised blood supply area. And the prostatic urethral stenosis, these are the most devastating, are associated with high energy ablation therapies like IFU, cryo, etc., or radiation with any of these options. So again, if we're dealing with bulbar membranous urethral stenosis, actually it should be called stenosis because the stricture is only portions of the urethra where there is spongiosum, and the bulbar membranous urethra has no spongiosum, so it should be stenosis, like prostatic stenosis. But people use either or both terminologies. So this is the strictural. This is the urethral site typically affected by radiation. And devastated bladder outlets, including bladder neck and prostatic urethra, or posterior urethra involving bulbar membranous urethra as well. These scenarios refer to or are associated with the refractory, recalcitrant stenosis, important necrosis, and/or end-stage incontinence. That in most cases these patients are irreconstructible. So when we have to deal with these patients, we should consider specific factors prior to treatment. What are the goals of treatment? To restore normal voiding, to preserve continence, or enable treatment of incontinence, to reduce upper tract complications, and to decrease infections. We have to look at patients' as a status and the longevity. That means physical fitness. We need to we need to look at patients' capacity to heal, and also physical and psychological impact of postoperative urinary incontinence and subsequent surgeries that these patients will have to undergo. So let's start with the vesicourethral anastomosis stenosis. What are the options of management? Self-dilatation, endoscopic treatment, open reconstruction, and as a last resort, urinary diversion. So historically, this condition has been or was discouraged, especially in patients after radiation. And it's still true that these post-radiation patients are not easy to deal with, to reconstruct, so they should be advised that urinary diversion may be their last option or definitive option. But if we embark on reconstruction, there are several approaches. The transperineal is one of the most commonly used by urologists. The abdominal approach, and combined the abdominal perineal approach, and lately the robotic approach. So so this vesicourethral stenosis is the most common site of obstruction after radical prostatectomy. Its incidence varies up to 20%, according to some studies. It's been said that minimal invasive procedures are associated with a lower risk of complications and with a lower incidence of this complication. De novo incontinence after reconstruction is not negligible. It's about it's not 2 or 7. Is 20 to 70%. There's a mistake here. And patients with a concomitant post-prostatectomy incontinence and bladder neck contracture are usually very challenging. And most of these patients end up with a primary AOS implantation after reanastomosis, and this is usually successful. So this is the most common site of obstruction after radical prostatectomy. As I said, this is again some repetition of what I said. This slide is repeated. Sorry. Let's move on to the transperineal approach. As I said, this approach allows you to perform complete excision of the scar tissue and the reanastomosis of the vesicourethral structures. In some cases, it implies crural separation and inferior pubectomy, just like the reconstructions that we do for pelvic fracture urethral injuries. The success rate is very high. According to some authors, it may range from 82% up to 100%. I never believed this 100% because I think it's only God gets 100% success, and sometimes you also make mistakes. But it's what's in the literature. It's not my experience, by the way. But The bad thing of this highly successful reconstruction is that at least 1/3 of them, only 1/3 of them, maintain continence. So most of them become incontinent and will need a sphincter. That's why this is considered a two-stage procedure. The first is the reconstruction, is the anastomosis, and the second stage, 4-6 months later, is the implantation of an artificial urinary sphincter. Sorry. So we've designed this simplified algorithm for surgical treatment of these conditions. Well, potentially, if we have a short stenosis, non-obliterative, these can be managed by minimally invasive approaches and proceed to more invasive if the first ones fail. However, the EAU guidelines are weak on this topic. The second group is the complex stenosis that will need open reconstruction. So minimally invasive treatments, there's a high risk of recurrence. At least more than half of them will sooner or later recur. But it's a viable option if the patient does not want to jump into a very aggressive option, and he wants to try his luck. It can be treated by minimally invasive options and proceed as needed. With minimally invasive treatments, the likelihood of cure is low, less than 10% at long follow-up, and there are limitations. We should acknowledge the limitations of these procedures, and we should know when to stop. It's not a good idea to keep dilating or incising these stenosis for the rest of the patient's lives, because if it doesn't work first time around, it won't work the second time, or maybe the second time around. It won't work the third time, and it's only getting the situation worse and worse. So we can give it 1 or 2 tries or 2 attempts. If it doesn't work, proceed with a more aggressive and more successful option. So what about open reconstruction? As I said, it was discouraged in most patients after radiation, and it's still partly true. It can be very difficult per se, but even in the absence of radiotherapy, because these vesicourethral anastomotic stenosis, as a consequence of radical prostatectomy, may be fused to the inferior edge of the pubic bone. It may be associated with delayed wound healing, and there are factors that influence the surgical plan and surgical success, like amount of radiation that the patient had, and the baseline incontinence. So in our department, we designed a very simple approach. Patients that had radiation versus patients that did not have radiation. So in case of no radiation, no prior radiation, we need to rule out the obliterative stenosis before reconstruction. So we do these urethroskopies, imaging studies, etc. And we recommend for these patients open perineal reconstruction. It's less invasive. It's not the easiest, but it's less invasive, and it's not like overkill, like when you need to do the abdominal perineal. These cases are for far more complex cases. Again, it's a two-stage approach because you will make these patients, most of them incontinent, and they will need an artificial urinary sphincter. Sorry. Let me see if I jumped. No. So in case of prior radiation, does adjuvant radiotherapy changes the treatment algorithm of these patients? Yes, or does it impact? Yes, it does. But in most cases, reconstruction is possible. So reconstruction is possible, but you need to be very, very careful in selecting the patient, and you need experience, because all reconstructions that involve heavy radiation is not for the, well, I don't want to be discourteous, but it's not for the beginner. This is a very complex field. So it should be reserved for tertiary high volume centers and people that do this on a routine basis. Even in those hands, it fails. So for patients that are unfit or do not want to proceed with this major reconstruction, we offer one of these options that depends on surgical factors and patient preference: urinary diversion or a chronic suprapubic tube. Some patients accept this option, or a continent catheterizable vesicostomy, which is not a very good option for the radiation patients, or a simple ileal conduit. So again, in presence of radiotherapy, if the bladder is unsalvageable, has low capacity, or in presence of a devastated blood outlet due to heavier radiation exposure, or cavitation, radionecrosis, a fistula, all these factors that deem these patients unreconstructible, we recommend urinary diversion. And the type of urinary diversion, as I said, depend on patient's choice, the manual dexterity, and an unwillingness to undergo revisional surgery. When you decide on the type of urinary diversion, you need to inform the patient that if he wants a continent diversion, the probability of undergoing a revisional surgery in the future is much higher than a ileal conduit. Patients may not appreciate that because they don't want to wear bags, but sometimes it's the best option. So what about open reconstruction? Perineal approach, I already said, covered this. This is the best option for cases without radiation. High success rate after primary reconstruction. As all options, they may need future endoscopic treatments to achieve patency, because in some cases there are small strictures that need to be dealt with an endoscopic procedure. So this approach is similar to the one that we use for pelvic fracture, urethral injuries. Success is lower if there's radiation involved, and there are some additional maneuvers that we can use to increase the success. So the retropubic approach is preferred by some authors. This is usually indicated if patients have preoperatively good urinary continence or reasonable urinary continence, because it minimizes urethral dissection and the risk of urethral or the sphincter the disruption is much less. The success rate is also high, up to 80%. Some additional endoscopic maneuvers may be needed in the future, and the procedures that are mostly used are the T-plasty, and currently this technique has been done via robotic, and it's a YV plasty. Well, at last, it's the abdominoperineal approach. This approach is reserved for very complex patients with a heavier radiation. The success has also been reported to be high. It's usually a two-team approach, one for the perineum, one for the abdomen. In our institution, we only use one approach, or one team. Sorry. This may require pubectomy or total pubectomy, and usually a mental flap to patch the reconstruction area. And this may be required in long stenosis or when the external sphincter is not functional anymore. So the success rate of this approach is also good, 83% at a minimum follow-up of 2 years. So in conclusion, open surgical reconstruction is the best treatment for recalcitrant vesicular urethral anastomosis. It's the only curative treatment. It may afford 60% or 100% of success, but it's a two-stage operation, and it's critical to have good bladder capacity. Otherwise, it's no use to reconstruct these patients if they will need some form of diversion or if they will be incontinent. So very quickly, I'll touch the other two complications. This is as a result. This is a result of energy ablation treatments. Luckily, this is not the most common form of complication that we face. Mostly, we face bulbar membranous urethra or vesicular urethral anastomotic stenosis. This was a multi-institutional study that we performed. I was the senior author in the study. We presented this at the AUA meeting in 2021, and this has already been published. So radiation-associated strictures that affect membranous and proximal bulbar urethra was the target of this study. These cases are challenging, and we compared EPA excision and primary anastomosis to oral mucosal graft dorsal-onlay urethroplasty. Actually, the latter the option has been used very recently. Most of these cases were done historically with anastomosis. So the aim was to compare these two procedures. And in conclusion, both EPA and dorsal-onlay oral mucosal graft were successful. There was no difference in long-term recurrence risk, but oral mucosal graft was best suited for patients with diabetes mellitus, obese patients, maybe because it was easy to reconstruct with a dorsal-onlay graft than anastomosis that involves, say, a more extensive dissection. So in another study, also presented at the last AUA, or 2 years ago, we compared also another multi-institutional studies. Unfortunately, these studies are retrospective. The study was submitted and accepted, but it's still pending publication in the Journal of Urology. The same authors, the same institutions, and we used oral mucosal graft dorsal onlay urethroplasty for patients after radiation and prostatectomy. And we again used dorsal onlay urethroplasty. This preserved continence in nearly 92% of the irradiated strictures, which is a revolutionary study when, if you remember, a few minutes ago I said that most of these patients were not advised to undergo reconstruction. And obviously incontinent patients, we have to tell them that they will not get continent, but they will get a patent channel for a sphincter later. So these are the last resort cases. So bladder, devastated bladder outlets, in most cases are not possible to reconstruct due to extensive necrosis of this anatomy, calcification, severe pain, and in some cases urosyncytial fistula that will demand pubectomy. So all these factors will lead to cystectomy and urinary diversion. And the options for a reconstruction of a devastated posterior urethra depend, as I said previously, feasibility of bladder preservation, of bladder capacity and function, and if the bladder is suitable for reconstruction or is unsuitable, for a reconstruction, we proceed with the bladder neck closure and the continent catheterizable channel. This is an example of a fibrotic and necrotic bulbomembranous urethra with calcifications. I don't believe that any one of you would consider the reconstruction or placement of a urinary sphincter in this patient. This is another example of a irradiated patient with a cavitation that contraindicates reconstruction. And this is another patient that had brachytherapy. He developed total obliteration, and this is nothing we can do other than urinary diversion. So the reconstructive options for a devastated bladder outlet, if the patient still has a reasonable bladder capacity, and but is incontinent, we should consider continent urinary diversion. I mean, cystectomy with continent urinary diversion. But if the patient has no bladder capacity, residual bladder capacity, we proceed with incontinent diversions, simple diversions, and bearing in mind that these options are associated with less revisions in the future. So if they need, or if they suitable for or eligible for a continent diversion, we in most cases do an Indiana pouch. Well, in conclusion, urinary obstruction is a common complication of prostate cancer treatments. I wouldn't say only prostate, but also rectal cancer treatments, because these patients receive heavier radiation. It's a serious morbidity. It involves serious morbidity and detriment to the patient's quality of life. We see some patients that come to us with dual bags, and they say, I was instructed or I was advised to avoid surgery because surgery was too bad, it was major. But this is the quality of life I have. I had radiation, I have brachy plus radiation, etc., and I ended up like this. So, because when you have a surgical complication, even if it's a fistula, a rectourethral fistula, it's no matter the size of the fistula, if it's a bigger fistula or a smaller fistula, the surrounding tissue is healthy. But if you have a radiated fistula, it may be very small, but the surrounding tissue is burned, is gone. So how are you going to reconstruct a small hole like this with a devastation, surrounding devastation like this? So these patients end up with diversion. And this is ironical because most oncological doctors advise them to avoid surgery. Well, that's a political issue. These conditions require a graded approach. We start with less invasive options first in some patients, like endoscopic treatments. In cases of completely obliterated vesiculourethral anastomosis, we proceed to supravesical diversion, and I will stay here. I will stop here. Thank you.
Thank you, Francisco. Any questions? Okay, Professor Achimovic.
When we are making a bladder neck resection after bladder neck stricture, we are insulating also mitomycin as 4 milligram into the scar tissue. Do you have maybe some patients that are receiving also in your hospital something like that, and about the results? Because I don't know, because we are controlling that patients, they're not coming back, but I don't know how it's working.
No, there's no solid evidence. Actually, I'm part of the EAU guidelines group on urethral strictures, and this is my chapter, the posterior urethral stenosis, and there's no solid evidence. Actually, a recent paper by Alan Morey, published in the Journal of Clinical Medicine, says exactly the opposite, that it was proposed in the past that injecting triamcinolone, well, steroids or mitomycin C, it would reduce or could reduce formation of say fibrous tissue. It's not been corroborated in larger studies, prospective studies. So I think you would be wasting your time. Just try endoscopic approaches first. If they don't work, proceed with surgery, with conventional surgery.
Profesor Achimovic, czy mamy pytanie?
For inferior pubectomy. And second comment, why urologists avoid to do this kind of surgery? I think the explanation is there is two kinds of urologists. One of them, they are just doing radical prostatectomy, no urethral reconstruction, and do urethral reconstruction. And when they are working perineally in lithotomy position, pelvis is black hole for those guys who dealing just with urethral reconstruction. Professor Perovic was my teacher, and I was curious why he asked me a few times to do together with me perineal prostatectomy. I think at first, when he first time asked me, I think that's competition between Professor Perovic and Professor Austoni. Professor Austoni also do perineal prostatectomy, and lately I understand Professor Perovic doesn't like to become a radical oncological urologist. He just like to learn prostatectomy to be good in posterior urethral reconstruction. So that's advice. If someone like to do these things, he needs to learn both surgery. Thank you.
Okay. Well, yeah, it was a long question, but let me try to. No, yes. In terms of the first part of the question was related to pelvic fracture urethral injury complications and no need to do pubectomy. Yes, most cases, I would say 2/3 of the cases, you can get along with the first two steps of the George Webster's elaborated approach. Mobilization of the urethra no, rerouting is the last step, the fourth step, and the mobilization of the and separation of the crural, so you can gain. And for each step, you gain 1 centimeter. I never understood. Maybe my geometry is very complex, or why rerouting the urethra you would gain one further centimeter, because you're losing the length of the urethra by rerouting it behind the corpora, the corpora cavernosa. But that's why I've only done 2 cases, and my success rate was 50%. One was okay, one failed, so I never did it again. The last part is actually the pubectomy, inferior pubectomy. That will the third step. That will increase 1 centimeter, but this is only in a minority of cases. In most cases, you can get away without reaching the third step. Only mobilization, distal mobilization of the urethra and the crural separation. The other part of the question was doing perineal prostatectomies. Well, I did a lot of radical prostatectomies when I did oncology, but I stopped doing this. Yeah, I stopped doing this because my younger colleagues are doing this robotically, so there's no point me doing this openly. Yeah, it is. Yes, and it gives you training, expertise to work in the perineum. But most of my radical prostatectomy, I did both, but most were retropubic. I found it more comfortable. I was trained like that, but I also did a few perineal. Actually, I think the incontinence rate is a little higher with the perineal approach. Not significantly higher, but it's a little higher. And you are mobilizing the distal urethra, where you need to keep the blood supply. When you do retropubic, you only mobilize the vesicourethral portion of the channel, so you don't get into the sphincter, which is further distal, and that's the advantage of the retropubic. But well, it's up to you.
Okay, thank you.
Okay.
Any questions? Thank you.